The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to the Healthcare Labyrinth Podcast, where we navigate the maze of healthcare policy and economics each week. My name is Marc Ryan, and thanks to everyone for listening in. Today, Medicare Advantage in 2027, a rate bump that's raising eyebrows, rattling insurers, and maybe, just maybe, shaking the entire system. Is this stability or a slow squeeze? We'll take our usual 3 breaks today, so let's get into it. All right, here's the headline. CMS just finalized 2027 Medicare Advantage rates, and the increase, about 2.48%. Now, that might sound fine on the surface, but in healthcare economics, that number tells a much different story. Let's rewind. Earlier this year, CMS announced that rates would go up just 0.09%, effectively flat. That was devastating news for Medicare Advantage plans, which are seeing huge increases in utilization. Some said it was as high as 9% late last year. I said that rates would land somewhere between 2% and 3%. That's based on how things usually trend between the advance notice, which comes out in late January, and the final announcement, which comes out in early April, especially as more fee-for-service data rolls in on costs from prior periods. But this year, something odd happened. I was right, but for a different reason. The effective growth rate, the EGR, which usually moves up a great deal, barely moved. Just a 0.36% increase. That's shockingly low in what's been described again as a high utilization environment. More care being used, but barely any reflected growth. That raised eyebrows immediately. But we still landed at 2.48% for a rate hike when all was said and done in the final announcement. So how did that happen? The answer: CMS backed off a major change it proposed. The agency originally planned to update the risk adjustment model V28 using newer Medicare data with 2023 diagnoses and 2024 spending. Instead, CMS pulled back. They're sticking with older data, 2018 diagnoses and 2019 expenditures, which is then trended. The same framework already phased in through 2026. And that decision, it's huge for the MA plans, because if they had gone forward, plans were staring down a major rate hit, wiping out most of the increase. Why did CMS pull back? Well, let's break it down. First, industry pushback. Plans argued newer data would distort cost realities, especially with some weird patterns in fee-for-service right now. Second, stability concerns. The V28 risk model already cut well over 7% out of rates between 24 and 26. Another hit could have been devastating. 3, politics. Let's be honest, a near zero increase heading into an election cycle, that could mean higher premiums, fewer benefits, and bad headlines right when midterm elections were happening. And CMS knew it. Let's follow the money here. That 2.48% increase equals about $13 billion in additional payments to plans in 2027, up from less than $1 billion. But here's where it gets spicy. Some argue the real increase is closer to 5% when you factor in risk score trends. Others say not so fast. Risk trends aren't free money. They reflect sicker populations and rising complexity. And under the newer V28 model, those trends are already being squeezed. I tend to be a bit in the middle on this issue, but think the MA plans had the better point overall, especially with V28 taking a propensity to overscore away. Some plans may also see more revenue than 2.48%, though. That's because CMS is also tightening rules around risk adjustment behavior. No more diagnoses from audio-only visits, no more unlinked chart reviews, with limited exceptions. Translation: less room for aggressive coding. And that hits the biggest players hardest. United Healthcare, estimated impact $5 billion annually. Humana, estimated impact about $2 billion annually. CMS pegs this change at a reduction of 1.53% in rates overall for the industry. But since this is concentrated on some of the largest plans, again, others will effectively see higher rates. While the headline increase is 2.48%, I still feel that some plans may effectively experience closer to 4%, depending on how exposed they are to risk adjustment overcoding. That is good news, well, in part. The big picture. In the end, CMS backed away from a very low rate hike and the further changes in the V28 model in an effort to try to balance impacts while still reforming the system through its unlinked chart reform. It balanced, as it usually does, short-term pressure on plans with long-term program stability. But the industry, again, they're not thrilled because in a world of rising utilization and cost pressure, 2.5% feels tight. Again, we are seeing huge utilization increases in the program. And that tension, it's not going away anytime soon. With that, we'll take our first break, and when we come back, we will discuss some of the star changes in the rate announcement. Be right back.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage and a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and thanks for listening to the Healthcare Labyrinth Podcast. I am Marc Ryan, and we are discussing the final MA announcement for 2027. We discussed the final rate hike for 27 and now turn to some of the important star rating updates, which are always in that final announcement. Honestly, not much change from the advance notice to the final announcement. Surely the final MA and Part D rule for 27, which was also recently announced, was enough for the industry. As a brief refresher on that, that is reducing the number of measures by star year 2029 dramatically, eliminating the easy-to-hit operational measures and a few others. That makes it tougher for plans to reach higher star ratings. Go to the podcast on April 17th for more info on that. For 2027, CMS largely held the line on star ratings between the advance notice and the final announcement. Here are the highlights again. Important deadlines for star year 27 and star year 28. For measure years 25, star year 27, a March 31 deadline to review all your CTM complaints data. That's already passed. May 18th, Part D drug measure administrative data review requests are due. June 30th, 26, Part C appeals data review requests are due. For measure year 26, star year 28, March 31, 2027, CTM data review requests are due. May 18th, 27, Part D PDE drug measure administrative data review requests are due. Note that these data review deadlines are before PDE and appeals, at least for reopens, have final data completion, and before what we think of as the end of the official closeout period, which is June 30th. Thus, MA plans need to thoroughly review data for discrepancies early and call out potential issues with data completed after the deadline. I don't think some of these deadlines are fair, but nonetheless, they are in the rule and plans must follow them. So let's get to star measure additions, removals, and changes for measure year 25, star year 27. Star year 27 will be announced in October. There are 6 new or updated measures for Star Year 27. Colorectal cancer screening. The age band will be expanded. That means normal guardrail limitations will not apply. Care for older adults functional status assessment. Concurrent use of opioids and benzodiazepines. Polypharmacy, use of multiple anticholinergic medications in older adults, poly-ACH. A statin tolerance exclusion was added to the statin use for persons with diabetes, SUPD. For diabetes eye exam, EED, the chart review option was removed. There are 3 measures being removed beginning with Star Year 27. Care for older adults, pain assessment, medication reconciliation post-discharge. This remains embedded as a submeasure in transitions of care. Medication therapy management program completion rate for comprehensive medical review. This will return to the star ratings as a new measure beginning with Star Year 29. A word of caution, don't be confused on statin therapy for patients with cardiovascular disease, SPC. It remains a measure in Star Year 27. In Star Year 28, it moves to the display page due to changes in the measure, but it is actually being sunset under the final 2027 MA and Part D rule. There are 2 weighting changes for Star Year 27, the Improving or Maintaining Physical Health, IMPH, and Improving or Maintaining Mental Health, IMMH, health outcome survey measures move from 1x weight each to 3x weight each. The complete measure table for Star Year 27 is included on pages 105 to 110 of the final announcement. It includes each measure, the weight, the measurement year, and whether it is counted improvement in CAI. Note that the final 2027 MA and Part D rule expunges the excellent health outcomes for all reward retroactively to Star Year 27. Instead, the reward factor is maintained. The disaster grid is published in the final announcement as well. For Star Year 27, there are 2 disasters that will be in play: the Los Angeles wildfires in January 25 and severe storms, straight-line winds, and flooding in 10 counties in Texas in July 2025. Note that the LA wildfires received a benefit in both Star Year 26 and Star Year 27 regarding CAHPS member satisfaction surveys, and will receive the better of the Star Year 27 and Star Year 26 CAHPS measure level star ratings. In some cases, this would mean the Star Year 25 measure level star ratings would apply. With that, we will take our second break, and when we come back, we will give you some details on changes on stars in coming years. Be right back.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve star scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and thanks for listening to the Healthcare Labyrinth Podcast. I am Marc Ryan, and we are discussing the final MA announcement for 2027. We're discussing some important star rating updates. There are several updated measures for Star Year 28, Measure Year 26. Medication adherence measures. A risk adjustment methodology is being implemented in the 3 medication adherence measures for Measure Year 26, which will drop to 1x weights for 1 year. The inpatient and SNF adjustments will also be removed. Statin use in persons with diabetes. PQA will add a denominator exception for those individuals with diabetes who do not have a prescription claim for a statin, but do have one or more prescription claims for a qualifying alternative therapy. These are recognized therapies for those with a statin intolerance. This will ensure better accuracy of the measure. The person would be identified as in the denominator if they have diabetes. A search of the recognized alternative therapies would then be made. If present, the patient would then be removed from the denominator. An analysis found that including the exception criteria had a negligible impact on the year of service 24 SUPD rates overall across all contract types. The change is deemed non-substantive. The change will be implemented for measure year 26 again. Again, I don't think this is really non-substantive, and plans should take a close look at it because it could impact them rather demonstrably. Polypharmacy use of poly-ACH drugs. PQA clarified how to identify beneficiaries in the eligible population with 2 or more prescription claims for the same target medication on different dates of service during the measurement year. The call center measures. The proposed 27 MA and Part D rule was finalized, and it will eliminate the 2 call center measures for STAR year 28. STAR measure changes for measure year 27 and beyond. There are a number of proposed possible measure updates for the out years involving plan all-cause readmissions, transitions of care, and diabetes blood sugar controlled. Some of these involve conversion to ECDS electronic measurement. There are some display measure updates proposed or possible as well. One more controversial proposal involves setting of cut points. CMS says it is continuing efforts to simplify the star ratings program and considering methodological enhancements to make the calculations easier to understand and implement. It is contemplating simplifying the methodology for determining measure thresholds. One possible approach being considered would use percentile distribution cutoffs to assign measure stars instead of the current clustering methodology for non-CAPS measures. The view here is that using percentiles versus clustering would be more transparent and make cut points more predictable. Notwithstanding all this, while things might be more predictable, it could also mean CMS uses the new system to essentially set the number of contracts at given star levels. With that, we'll take our last break, and when we come back, we will discuss some of the key takeaways from the final announcement. Be right back.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and thanks for listening to the Healthcare Labyrinth Podcast. I'm Marc Ryan, and we are discussing the final MA announcement for 27. So who wins here? Who loses? And what should plans actually do? The winners, plans with conservative coding practices, organizations already adapted to V28 constraints, and those focused on true clinical risks, not documentation games. The losers, heavy reliance on chart reviews and coding intensity, plans slow to adapt to data and compliance tightening, and to anyone expecting a big rate rebound. This is the key takeaway. The game is shifting from coding optimization to real risk management, and that will continue to be seen in rates moving forward. That means better care coordination, smarter utilization management, real clinical impact, because CMS is clearly signaling we're watching and we're tightening. So where does this leave us? Let's call it what it is. This is a modest increase in a high-pressure system. CMS avoided a real shock this year, but they didn't open the floodgates either. Instead, they're walking a tightrope, keeping plans solvent, controlling spending, and cracking down on abuse. And all of that while utilization keeps rising. Thanks for listening to the Healthcare Labyrinth Podcast. If you enjoyed today's episode, be sure to subscribe and share it with colleagues interested in healthcare policy. Until next time, stay curious, stay skeptical, and keep navigating the healthcare labyrinth with me. We will find our way out together. Again, I am Marc Ryan. This is the Healthcare Labyrinth Podcast. See you next week. Take care.
Thanks for joining Marc and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.